the entire world essentially on this 3D pathway. So all the things we know about 3D, essentially we know from Luigi, Denisa, and then his mentees, among which you are one of them. So Luigi, you're on. I will apologize that I have to sneak out to do my hospital rounds. I know your talk will be fantastic, and hello to all the friends back home.
Thank you very much, Sorin, for these very nice words, and also thank you to Sorina, Magda, Bogdan, Dragos, and all the scientific committee of this meeting for inviting me again. It's a lot that we didn't met in person. It seems another era of the world, and it's hard to remember when we did it, but meeting through web, it's only partially compensating it, but it's better than nothing. So the topic is imaging reinvented to assess the risk of sudden cardiac death and arrhythmias in heart failure patients. As a first sentence, I would say that I didn't reinvent anything, but I will try to show you some nice data that we can get from current imaging modalities to stratify those patients. So let us start from the end. So when we realize then a patient is classified at a high risk of a sudden cardiac death, the better treatment that we have is the implantation of the ICD. And following the latest guidelines, we are allowed and we recommended to implant patients have been treated with optimal guidelines, guided medical therapy. And this is true for the patients, particularly with primary prevention, and then we have also patients who also had an arrhythmic events as an aborted sudden death or a high risk ventricular tachycardia that should be recommended as well. The problem is that with the current guidelines, with the current indication to the implant of the ICD, we are not doing really a great job. Because as you see in this meta-analysis, with all the ICD, we are going to implant only a minority of them deliver appropriate shock therapy to the patients. Most of the ICD never work because there is no arrhythmia to shock, and some of them, at least up to 12% of the patients with an ICD will experience adverse event in terms of endocarditis, malfunction, or inappropriate shock during their follow-up. So there is a problem in the appropriate selection of those patients, and what we will discuss today is how to use the imaging to do that. First of all, let us look at the epidemiology of the sudden death, and we see that this is really a big problem with a lot of patients dying of a sudden death per year, and the epidemiology is with the prevalence in males in most of the age group and increasing with the increasing age of the patient. This is also paralleling the epidemiology of the coronary artery disease that will be the main cause, as we will see. What is important from this review is to look at the distribution of the left ventricular ejection fraction in those patients who underwent sudden cardiac death. And you see that more than 50% of those, and actually 70%, have an ejection fraction that is higher than the threshold put by the guidelines of 35%. So there is a large group of patients that, according to the number of the ejection fraction of their left ventricle, despite being at high risk of sudden cardiac death, will never receive an ICD. And the current effort of cardiologists and of research is to try to identify this large portion of the iceberg that is under the water and cannot be seen. We know that in those patients, the incidence is really low in terms of percent, but this is the vast majority of patients who have a structural heart disease. And so at the end, despite the very low incidence of a sudden cardiac death, the absolute number of events is the vast majority proper in this group of patients with EF more than 30%. This is also shown in these two graphs that I have taken by the Brownwell textbook of cardiology, that is also showing often neglected problem, is that patients with low ejection fraction don't die only of a sudden death. And as low as it is the ejection fraction, more and more patients die for non-sudden death. So in those patients, despite the low ejection fraction, the implantation of an ICD would be absolutely futile. In this slide, I tried to summarize all we know today about the stratification of sudden cardiac death risk in a patient with heart failure. You see that the clinical factors as well as plasmatic biomarkers have been tested. Those are not exactly the one that will help us in identifying patients who are at risk of a sudden death, so those who have to be implanted with an ICD, but mostly they will help us in identifying patients who are at the end stage of their heart failure. And so they are most likely to die for non-arrhythmic cardiac death, and in whom the ICD will not be effective. Then we have genetic testing. This is mainly for non-ischemic pathopaths. We know, and we will hear in a moment by Bogdan Popescu about hypertrophic cardiomyopathy, but also other cardiomyopathies like dilated cardiomyopathy or arrhythmogenic cardiomyopathy have a high predisposition for sudden death. QRS dispersion on electrocardiogram has also been used, not very sensitive but very specific. And going to the imaging modalities, we have the 123 iodium scintigraphy to assess the cardiac sympathetic function. That is particularly useful in patients with borderline ejection fraction, when we have to decide if the patient is worth to be implanted or not. And then, of course, echocardiography is the mainstay of the stratification of the risk, and is the technique on which the guidelines are based. And in patients, we will see in whom echocardiography cannot answer the question of the LV ejection fraction. It's also cardiac magnetic resonance, and also with cardiac magnetic resonance we can perform in tissue characterization and locate and quantitate the content of late gadolinium in the myocardium, that is a substrate for arrhythmias. But the main thing is echocardiography, and I will concentrate my talk about echocardiography also for the sake of time. And we know that the recommended technique to assess the ejection fraction is the two-dimensional echocardiography, the biplane method of disc. And when the images are not good enough, or we have doubt on the correct assessment of left ventricular ejection fraction, CMR is, and even CT, even if CT is very rarely used for this task, is also recommended by current guideline. Just a few comments about two-dimensional echocardiography measurement calculation, I would say, of the ejection fraction. You know that the most important point, and also the most neglected in clinical practice, is to avoid the foreshortening of one of both the four-chamber and the two-chamber apical views that we use to calculate the volume and derive the ejection fraction. This is absolutely critical, because if one length is shorter, more than 10% than the other, then the level of the short axis in the four chamber and the two chamber is misaligned, and we cannot have a meaningful calculation of the volume of each disc that then will be summed up to provide the final volume. Then we have also problems when the two views are not correctly oriented, and it happens in most of the patients acquired routinely. Finally, I will show you that despite being relatively robust as an algorithm, but the biplane method of disc also have geometrical assumptions that are not met in most of our patients with geometric distortion of the shape of the left ventricle. Just to show you one example, I will show this case, 56-year-old man, type 2 diabetes mellitus. In 2013, he had a thoracic pain that was misinterpreted probably as an episode of respiratory infection. In 2015, occasional ECG showed QS complexes in precordial leads, and the previous echo said apical motion abnormalities with an ejection fraction of 64%. And these probably are the images that have brought to this assessment, as these are the images that have been taken by one of our fellows. But when the left ventricle is properly elongated, you see that it's not anymore 64%. And also, you see that the four chamber and the two chamber doesn't tell the entire story of this ventricle, because it's not only the apical part of the ventricle that is compromised, but also you see this large aneurysm of the medium apical part of the anterior septum that is usually neglected from the conventional computation of ejection fraction by 2D echocardiography. So a 2D assessment of, sorry for the Italian here, assessment of the ejection fraction in these patients was 39%. But once again, two-dimensional echocardiography doesn't take into account what happens in the apical long axis view. And if we move to 3D echocardiography that takes into account the contribution of all 18 segments of the left ventricle, you see that the ejection fraction drops to 33%, and 39 and 33% tells a completely different story in the management of those patients. Since of the controversial results of echocardiography, the patients, of course, underwent CMR that documented and confirmed the extensive wall motion abnormalities and the severely reduced ejection fraction. So here you see that using the conventional Simpson biplane, you don't implant the ICD, while advanced echocardiography, namely 3D echocardiography, as well as CMR, is indication for the ICD. But as a matter of fact, the recommended technique is still two-dimensional echocardiography, even if in the clinical practice this is not anymore. And another advantage of 3D echocardiography that was documented in this nice paper by Dinesh Paladin and Tavendiranathan is the fact that among all the echo techniques to calculate the volume and the ejection fraction of the left ventricle with or without contrast, 3D without contrast is the one with the highest reproducibility, the highest test, retest, and inter-observer reproducibility. So it's the recommended one. A couple of years ago, one of the fellows in our lab, Mexican colleague Hugo Rodriguez Zanella, explored the added value of measuring the ejection fraction with the 3D in the indication of to ICD in 172 patients that were followed up for almost 3 years. And what was important is that using the conventional 2D echocardiography, out of the 172 patients, 63 patients would have had the indication to the ICD. When those 63 patients were reanalyzed with the 3D echocardiography, we could exclude 3 patients from the ICD. And when we look at the outcome, only one of these 7 patients would had a major arrhythmic events that could have been part of, because almost all those patients would have received an ICD, so would be an excess of expenses, but the patients are protected. The big important part of the graph is the right one, the 109 patients that would have been excluded from the ICD implantation using the two-dimensional EF criteria. Almost 1 out of 4 of them using 3D would have received an ICD, and you see that more than half of them would have experienced a major arrhythmic event that could have been prevented by the ICD. So with the 3D echo, we can include in the prevention of ICD even patients that normally are excluded. But as you know, and you all can teach me, because most of the research about this topic comes from Romania, the ejection fraction is just the parameter of the pump function, but we don't look at the muscle. To look at the muscle, we can use the speckle tracking echocardiography to assess really the myocardial function. And here is one of the major steps forward in the use of echo to stratify the risk of sudden cardiac death brought by the group of Oslo. Christina Auga was the main driver of this line of research, showing that we can measure the time from start of the QRS to the peak of the segmental strain curves, and making the standard deviation of those times to obtain a mechanical, a so-called mechanical index that is a parameter of the mechanical dispersion inside of the left ventricle, and is related to the content of fibrosis. And the highest is this mechanical index, this standard deviation, higher is the risk of potentially lethal arrhythmias in those patients. This is important and has been published in several papers in patients with ischemic cardiomyopathy, and that has been done. But there is not only coronary artery disease. Even if coronary artery disease is the large majority of patients who are at risk of sudden cardiac death, there is another important number of them with cardiomyopathy, and then there are 5–10% of patients with no apparent structural heart disease that that are at risk of sudden death. And these are the most challenging to identify, and also are also the most vulnerable part of the population, because usually they are quite young, active, and otherwise healthy. And here is where the speckle tracking can play a role. In those patients that are the young adults, the cardiomyopathies, but also the channelopathies are important causes of sudden death. And not only, but there are also congenital heart disease. This is the second case that I want to share with you. This is a 13-year-old boy with a cardiac arrest, and he was luckily he was resuscitated. And at the echo, at the after admission, you can see regional wall motion here in the septal part of in the anterior, in the apical part of the anterior septum, cardiac CT, and also the strain can identify quite a very well delimited region of severely reduced regional strain compared to the rest of the left ventricle, anterior septum, anterior wall, and part of the lateral wall. And this is quite a marker that there is something wrong in the entire left coronary artery, and indeed the CT as well as the coronary showed the anomalous origin of the left coronary artery from the pulmonary artery as a main cause of the ischemia and arrhythmia in these patients. So we should pay attention also to congenital heart disease. The case 3 is a typical case of lung QT syndrome. We have lung QT corrected, that is 660 milliseconds. The patient had a syncope, cardiac arrest with ventricular fibrillation, has documented over years. Healthy individuals that, despite the long QT syndrome, have a normal contraction duration from those who have a prolonged contraction duration. And not only it's an overall contraction, but it's also transmural myocardial dispersion in long QT syndrome, where the subendocardium is longer than mid-myocardium. So you have a sort of transmural mechanical dispersion, and this transmural heterogeneity is not present in asymptomatic carriers of the gene or in healthy individuals. And so it's important to identify those patients. And when in these patients published several years ago in Circulation, Christina Auga showed that patients with mechanical dispersion by longitudinal 2D spectral tracking was a powerful discriminator events from patients who will not. Just to finish about the contribution of echo, this is my last case with unexplained cardiac storm and several episodes of ventricular fibrillation that have been shocked in a young man with no cardiovascular risk factors and also left ventricular dysfunction and normal coronary arteries. You look at these patients, the original wall motion was absolutely extensive with a wall motion score index 2.5. The strain is awful, -5, and the mechanical dispersion, of course, was very, very large. Well, in this patient, you can think of everything, ICD, cardiac transplant, or whatever, but you should also think at sarcoidosis. And this was exactly the case. The evaluation of the ejection fraction in this patient, the ICD, but if you treat it, if you make the correct diagnosis and you treat it with corticosteroids, you can have astonishing results. And this is the two echoes performed in the same patients 6 months apart, showing a stunning recovery. It is a summary on admission, global strain -5, LV function 25, after corticosteroid therapy, the strain increased to -15, mechanical dispersion almost halved, and ejection fraction was just mildly reduced. So just to conclude, despite the primary prevention of sudden cardiac death is currently best achieved with the ICD in patients where the LV ejection fraction is less than 35%, we should